Welcome to the program Health and Beyond. In this program, we have up-close interviews with professionals in the health sector to enlighten communities on health-related issues as well as other topical issues beyond health. The program comes face-to-face with people who have valuable information for public consumption. It's another edition of the program Health and Beyond. It's always a privilege to have you with us. Today, our topic is prioritizing maternal and child health. We have a full studio with us here today with some experts whom I would like to start with self-introduction, beginning with Mr. Munjo.
Good morning. I'm called Munjo Anthony. I'm a midwife and a program director for Advanced Life Support and Obstetrics for the CVC Health Services in Cameroon, and I'm administrator of a Tukere Baptist Hospital.
I'm Rahel Mba Bayer. I'm a public health analyst, and I double as the program coordinator for the Advanced Life Support in Obstetrics and also research projects being done by the University of Alabama at Birmingham here in Cameroon. Thank you.
I'm Dr. Forchak Nielsen. The first batch of residents from the Faculty of Health Science, University of Boya, in obstetrics and gynecology. And I'm here today as one of the facilitators for the Advanced Life Support in Obstetrics program, which is organized or piloted by the CBC Health Services of Cameroon.
Thank you. So I would like us to talk about the key words in our topic today. We have maternal, we have child health, before merging them to allow our population to understand what maternal child health is all about.
Okay. Maternal health, when you say maternal and child health, in reality is just one aspect of public health that's at the global scale. It is that part of public health that deals with what? It deals with the well-being of mothers, it deals with the well-being of pregnant women, it deals with the well-being of newborns, it deals with the well-being of toddlers, and as well as it deals with the well-being of children, that's under 5 children. The idea behind maternal and child health is all about trying to promote, it's all about preventing or reducing maternal mortality. It's all about preventing or reducing neonatal mortality. It's all about preventing and reducing under 5 mortality. It also encompasses promoting maternal. So there's some kind of also health promotion aspect of it. It's not just about all the resources we put in place to prevent maternal death. No, it's also about health promotion.
Okay, thank you. Madam Ba, I know that you're also involved in research with maternal and child health. Now, you tell us, why is this important, what Doc has just talked about?
What Dr. Forchap just talked about, I think maternal and child health is very important because it's there to provide basic needs to mothers and children. You see that now in the world, especially in the African context, we see that maternal mortality is still a cause of concern. And maternal and child health is there to reduce maternal mortality and morbidity. It's also there to reduce prenatal and neonatal mortality and morbidity. Also to prevent malnutrition. You also prevent communicable diseases. We are there to see how we can promote reproductive health, amongst others.
Yes, Doc, what would be your assessment of maternal and child health in sub-Saharan Africa? I would like us to Talk about this with a special focus on Cameroon.
Okay. Well, we will have to go back to 2015 where the the United Nations they actually came up with the Sustainable Development Goals, and the rationale for that was like they're trying to see how they can reduce or improve healthcare as a whole.
Yes.
Now we'll talk about Sustainable Development Goal 3, the third of the SG Group 3. Realize that the first aspect we are talking about maternal health. And what was the idea behind that? They're trying to say that by 2030, we should, on a global scale, reduce maternal mortality to less than 70 on 100,000 live births. We are in 2026. Interestingly, maternal mortality in Cameroon, as of now, we are at about 258 per 100,000 live births. This tells you that Cameroon, on a global scale, they've been doing their own part. It's true that we've not been able to attain that objective, but the government of Cameroon and its global partners and the stakeholders, they've done a lot. For example, if you go back to 2018, you realize that maternal mortality was about 408 per 100,000 live births. So 2018 to 2026, there's some improvement, there's some effort that have been put in place, and we are now seeing the results. Now, why is it important? It is important because maternal mortality is an index for development of a nation. To see that your country is developed, to see that you're improving, the first question I'll ask you is, what is your maternal mortality ratio? And so it is why, like I said, the government of Cameroon and its global partners, they are putting a lot of efforts in trying to reduce maternal mortality. So maternal mortality is an index of development, and so everybody has to put their hands into this global fight. Now, the question is, when we say maternal mortality, what about the other aspect? What about neonatal mortality? And that's how we go back to our initial question. We're talking about maternal and child health. You cannot talk about maternal mortality without talking about neonatal mortality. You cannot talk about neonatal mortality without talking about under 5 mortality. And so, if you go back to the same SDG goals, realize that the SDG goal for neonatal mortality, which we are supposed to attain by 2030, is supposed to be less than 12 per 1,000 live births. So far, as of 2023, we are about between 24 to 26, which tells you that neonatal mortality is still a call for concern. So how do we put more effort? And I think that is one of the reasons why we are here today, to make people understand that maternal mortality or maternal health is something that we all are supposed to do our own part to make sure that women don't die, women don't have complications when they give birth. Children are born in a very safe environment. Children grow up in a very safe environment.
So tell us, what can be done differently from your analysis and from your statistics? You've made us to understand that maternal mortality, neonatal mortality, and postnatal mortality, that's still alarmingly high. So what is happening and what can be done differently to prevent this?
Okay. Maternal mortality is not a problem of the government alone.
Yes.
You see, we have the tendency of saying that it is the responsibility of the state to make sure that people are safe. Maternal mortality is a fight for everyone, it involves everyone. It involves all the stakeholders. It involves the patients. It involves, we call them our clients. We now avoid saying that we call the pregnant woman a patient.
Patient is a client, yes.
So everybody has put their hands into play. And that's why if you look at you're asking about what can we do. Now, how do we reduce maternal mortality? Because it's a key indicator that we're talking about here. There are a lot of things that we can do. We'll be talking about the advanced life support in obstetric training program. There are other training programs that are put in place to see how they can capacitate health personnel to be able to attend to these emergencies. Because when we talk about maternal mortality, what the number one cause of maternal mortality, for example, in our context is hemorrhage, postpartum hemorrhage. And so, how do you reduce maternal mortality? To reduce maternal mortality, efforts are supposed to be put in place to see how we can reduce postpartum or fight against postpartum hemorrhage. And that's why the advanced life support in obstetrics has comes in. There are other emergency bundles that come in to see how we can reduce postpartum hemorrhage. And so that's why we are training many people, we are training healthcare personnel, we are even involving stakeholders to see how they should see the importance of addressing or fighting against the emergencies when it comes to obstetrics. Because we know that you want to reduce maternal mortality, you need to fight against postpartum hemorrhage. You need to fight against the second cause, which is the hypertensive disease in pregnancy. And of course, you have infections like sepsis and other complications. So the ALSO program, which will come up, we'll still talk about it. You see that the ALSO tries to bring evidence. We're talking about evidence-based medicine that has proven to work elsewhere. And so the government of Cameroon has also adopted it. And that's why the CBC Health services are now implementing this program at the national level. And currently, for example, we are here in Berlin at the moment, and we are training health personnel in the fight against maternal mortality. We are trying to capacitate them to see how they can address or attend to emergencies when it comes to obstetrics.
Yes, the government is doing quite much. Health personnel are doing a lot. As a midwife, Mr. Munjo, I would like you to tell us something regarding these deaths. Because as a midwife, I think you are also a frontliner as far as working with pregnant women is concerned. And now, how do you feel as a midwife when that happens?
Thank you. So, how I feel when a maternal or neonatal death occur is a devastating instance because when pregnancy occurs, the parents or the mother and the partners, they have one expectation to have a live baby and happy, and they usually make preparations everywhere in the world. Everybody is thinking about how they will name the children or child that is to be born, and they will prepare on how they are going to grow the child. So if a mother of the baby dies during childbirth, it becomes a huge burden to the family and to the community. It scares people who are still expecting to get pregnant. It makes this the what is supposed to be a happy event a sad one. And so the service provider like me, for example, you get devastated, you get overwhelmed, and you are trying to ask the question. Sometimes some people have resigned from the profession because they feel discouraged. They don't want to identify with such instances. So it's something that if you, I remember way back when I was still a child, one of my neighbors gave birth to twins and passed away. And the husband didn't know what to do. There was no money to buy milk. And also, fortunately, we had waiting mothers who showed up to breastfeed those children. Otherwise, you can imagine what would have been the future of those children today. So you cannot overemphasize the need to curb this phenomenon. As far as it concerns human ability, preventable maternal deaths are supposed to be pursued with all the energy that it is needed. Of course, there may be some circumstances that cannot remedy, but we are working towards making sure that if a woman must die during childbirth, it should be that it was really a death that it cannot be prevented.
Okay, and now we also talked about postpartum hemorrhage as one of the things that lead to maternal deaths. Yes, let's find out from you. Can this ever come about as a result of the absence of blood to transfuse?
Uh, what we don't want to get to the level of transfusion.
Okay.
Yes, so the intention, what the strategy WHO puts in place and the government in Cameroon is making sure that it's implemented is that all women, irrespective of their previous history about hemorrhage, should be actively managed when the baby is born to make sure that bleeding is not minimized, is prevented. And so if it occurs, when it occurs, there's the need to have blood transfused because the whole human being has just 5 liters of blood. So it is easy to lose that quantity when the uterus is not contracting after birth within 5 minutes. So there's need for blood to be available in the bank, and there's also need to have mobile blood banks, which is found in the blood transfusion associations, so that in the case where there's active bleeding, there should be people that we can bleed and give fresh blood to the client, because that is what helps in the clotting factors. So every maternity should have at least a mobile bank, which is the blood donors who know that their blood groups and they are eligible, they know what it means to stay healthy, and then a blood bank that keeps blood that has been stored, so that in the case of such emergencies, in fact, there are advanced hospitals like Gyneco Obstetrics and the Central Hospital in Yaoundé and the Regional Hospital in Douala. They have, they can separate the blood into parts. They have red blood cells stored and plasma, which are also components that in the case of acute bleeding, they are used, and the results have been proven to be very effective. So we are moving towards that to make sure that every service provider should be able to afford at least a fridge that can store those blood components to make sure that in an emergency situation, these blood components are available to rescue the lives of the mother.
Okay, we've actually done an elaborate program on blood donation, and so we'll not be talking so much again about that, but we just had to mention that, especially as you mentioned, postpartum hemorrhage. I would like to find out also, is there some of this responsibility that goes back to the clients, the pregnant women, the communities, some of the things that they're supposed to do that they are not doing?
Okay. Now we have to understand that pregnancy is not an illness; it's a physiological state,
Yes.
and it takes 9 months. We say 40 weeks in the hospital for a woman from conception to the time where the woman actually gives birth.
Yes.
Now you see that within that period of time, there is a series of things that lady has to do. That's in what's her own responsibility. And we will now talk about the importance of antenatal care.
Okay, right.
Because when you look at the goals of antenatal care, it will tell you that the first reason is that you want to bring about health promotion. They will tell you that you want to identify high-risk pregnancies. They will tell you that you talk about primary disease prevention, and that's why when the woman she has to start antenatal care as early as possible, so that you give her a fansidar, you give her a mosquito net. You see, we start talking about iron and folic acid supplements to build up her iron and folic her stores and boost her up so that she should not have low hemoglobin levels during pregnancy.
Yes.
And preparation for labor and delivery. Now, the question now is, how many times or how often is a woman supposed to attend antenatal care? Because for you to talk about preventing postpartum hemorrhage, it starts with preconception, the pregnancy, and labor or delivery itself. What am I saying? I'm saying that during pregnancy, these ladies have to come for antenatal care. A woman who doesn't come for antenatal care will not receive optimal services. You see. How, and if she's not, for example, taking an iron and folic acid, or when you come, for example, you do a hemoglobin level and realize that maybe it's low, you have ample time to see how you can catch up. Now imagine that she comes all of a sudden maybe at term and you don't know if you are meeting her for the first time. It becomes very, very complicated. So that aspect of responsibility is that the mothers have a very important part to play. They have to understand that they have to come for antenatal consultation and take whatever they're telling you very, very serious. Because if you don't do that, what will happen? She'll come at 10, and for some reason you ask her, Madam, what have you done? She'll tell her, no, maybe I'm an old room. I talk, I don't born plenty time. And she trivializes many things.
Forgetting to know that every child is different.
Yes, exactly.
Every pregnancy is different.
Every pregnancy is different. Every labor and delivery is different. Every postpartum after delivery is also different. And so that's why the starter kit is very important, because that aspect of health promotion tries to see how they can educate these women. If she doesn't come, it becomes a problem. Now, on the part of the government, because we talk about who has the responsibility.
Yes.
The government has been doing their own part, you see. For example, what we are doing now is part of health promotion. It's part of sensitizing the population to understand that if you want to see that, okay, if you're pregnant, you want to have the best possible outcome, then you know that you need to attend antenatal care. You know that you need to follow what your doctors are telling you. You see. Now, we said that the number one cause of maternal death was postpartum hemorrhage, right? One of the milestones, for example, one of the key milestones when you're following up a patient during pregnancy, that at 36 weeks, there is a series of tests that you do.
Yes.
And one of them, notably, is a full blood count. Why are you doing that? They're doing that because you know that, okay, you have a period of about 1 month that should give birth. And now within that period now, you do your full blood count. If it's low, if it's too low, maybe you start telling her mother, you have to get 1 or 2 blood donors. If it's maybe there's moderate anemia, for example, you tell her, okay, maybe you give you some iron and injectable iron to see how you can beef up the blood levels.
Yes.
And anticipate, because what do you want? You want to make sure that every woman who comes at term should have hemoglobin level of at least 10 grams per deciliter. And so that the rationale for doing that full blood count is that you want to make sure that you catch up all those patients that come with low hemoglobin levels before term, and see how you can anticipate when she comes, eventually comes to labor. And if the woman does not come, for example, at that period of time, and just appears in the hospital, then it becomes a problem. It puts now the health personnel in great danger.
Yes.
Why? Because they have to start rushing around. One of the important aspects of reducing maternal mortality is anticipating for complication. You cannot anticipate for a woman's complication when she comes in front of you the first time. If you have been following her up, maybe she has high blood pressure, she's diabetic, you see, she's malnourished, for example, she's not taking her iron and folic acid supplements. You have enough time to counsel her. You see, that health promotion is very, 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 very important.
Very important.
Yes.
And this is part of the health promotion.
Yes, exactly.
From the research that you are doing, what are some of the things that you've seen, especially aspects like access to maternal and child health and other aspects that we think really needs to be normalized to improve uptake of the services?
Okay. Well, we have to go back to, you're talking about access to healthcare.
Yes.
And come back to our context. There are a lot of things, because for you to talk about good quality ANC, these patients need to have access, of course. They have to have access to this hospital,
yes,
these facilities now. These personnel have to be trained to be able to address the emergencies, to be able to offer optimum antenatal care consultations. So now, the question now is, looking at the figures that we are seeing today, with the staggering figures of maternal mortality that we're having today, now how do we reduce that? We'll come back to the access to antenatal care. We'll come back to all the package that we're talking about, maternal and child health promotion. You see, bringing stakeholders to see whether, for example, in enclave areas, for example, how can we see that the people in that enclave care can have access to good quality antenatal care? You see, which makes us to understand that we have different levels of responsibility.
yes.
The state of one part has to see how they can make these health facilities accessible, affordable. You see, to this, to the parturients, also to our clients. Let's put it that way. Now, at the community level, there are other things that can also hinder these women from coming to the hospital. I'll give you an example. If you go to an environment where, for example, people don't find it, or they are used to maybe giving birth at home, that's a community or a cultural thing.
Yeah.
So how do you address that? That becomes another problem. And that's why addressing these barriers, you have to take into consideration the context. For example, we are in the Northwest, for example. How do the people, for example, maybe in Babogo, for example, how do they perceive antenatal care? How do they look at the importance? What importance do they place on maternal health? And those are other things they have to take into consideration. And you also have partner organizations, for example, maybe UNICEF, you see, WHO, UNFPA, and all of that. They also have to come and see how they can help the government, help sensitize this population, and see at the end of the day that global package is made available to every woman, be it in my village in South Maybe and then that is maybe you need to travel for like maybe 4 or 5 hours to get there.
To get there.
So it becomes a problem. So access to healthcare is really a problem.
It's a problem. That makes me to
Just can I add something?
yes.
Yes. So just in terms of access, Doctor mentioned the issue that some people deliver at home. What the CBC Health Services has done over the years is that we have a Life Abundant program, program that is being sponsored by Bread for the World, and we have community workers that have been trained. We call them community maternal and child health aides. We have nurses that work in that program. They are in hard to reach communities. So what we have done as a program, we have a basic life support in obstetrics that we started from 2012, and we have trained nearly all the community maternal child health aid workers in those communities. And the result has been very outstanding, because before then, we had people who left those communities and they were flown by helicopter and they reached the hospitals, and some of them, the outcome was not good. So what we've done was to make sure that we train these community workers to know which are the cases that they have to not keep, just to emphasize on the importance of antenatal clinic. When they have these women and identify that they have delivered before up to 4 children, they know that they will not deliver. They will start educating them to move to a maternity village like in Bingo or BBH, or to Bafut, their Catholic institution that people go there and stay 1 month before they deliver to avoid complications that cannot be managed in those peripheries. And we have trained them to be able to know even those mothers, bed attendants, traditional bed attendants who were not trained. We brought them in and trained them, because they are earning a livelihood from that service. And to say that you stop them, the community, those mothers already believe in them. So what we did was to capacitate them, to teach them, give them the skills and the knowledge of what they are supposed to keep. And for the past 5 years, we've not registered any maternal death at the level of the primary health facilities that will run out of the 54 that we have in the CBC, because they know now that they need to move these women out on time. So that's one of the successes that we can count on as far as ASO program is concerned, because it has improved at least those areas that the CBC is working there to help to accompany the government in implementing this strategy.
Now, just to add one key aspect which most people will tell you, or most of our mothers will tell you that, doctor, I don't get money. Mamas, I don't get money. We don't have money. And so that financial barrier is one of the things that people have been raising over the years that could be one of the reasons why we are having very high maternal mortality rates.
Yes.
And for that reason, you realize that the government of Cameroon, the public hospitals, they are not talking about universal health coverage. So a pregnant woman with just 6,000 francs, for example, she just applies, gives her 6,000 francs, they register her with the health who is having maybe an emergency in obstetrics, or she's bleeding, for example. How do you make that decision? And all of that. And so, out-of-pocket funding is what the government is trying to see how they can try as much as possible to say that no, if you are sick, you do not think that maybe because you don't have much go to the hospital. Nowadays, you have universal health coverage, and so not having money should not be a reason why a woman should stay at home and refuse to go to
the hospital. I remember one of the missionaries who is working with the Mbingo Baptist Hospital told me once that there are so many of the patients who go to the hospital at a time when it is almost too late. And it is the same situation when families say they don't have money to handle a situation, until it gets worse. So the program we are doing is part of advocacy, especially in access for people in our communities to access health care. I think when Mr. Munjo was talking, he mentioned traditional birth attendants and some of the work that the CBC Health Services as an institution does in the communities through the Life Abundance primary health care. That it's one beautiful thing with the Cameroon Baptist Convention in that we make sure that we have our roots into those communities. We find out the problems in those communities and we work with those communities to ensure that we give them quality services as far as healthcare delivery is concerned. And also when you were talking, you talked about context. That is always important to understand, even the context in which we are working. And that is why when we talk about context, training traditional birth attendants in such contexts makes it important, because personally I've been to communities where the communities rely a lot on their traditional birth attendants. And so when we train them, it gives them the opportunity to do the work properly. We are going to be coming back to try to know the cascade of personnel that work in healthcare delivery, and also to know some of the myths and the misconceptions that are in some of these communities that we would like to dispel, or that we've been dispelling and we still need to continue to talk about. So those are the two things I want us to discuss now.
Okay, you talked about myths and misconception when it comes to maternal and child.
Yes.
We have to elaborate on that. Maternal and child health is not just the pregnancy of this or no. We have preconception. You have the pregnancy. You have labor.
Yes.
You have the early postpartum. And then you have now, maybe after the what we call the preparing period, where all the physiological change of pregnancy must have left the finish from the woman's body, and now she looks like a woman who is not pregnant.
Yes.
Now, what are the needs for, I would say, conception before that's preconception? Now, I was talking with one of my colleagues during this conference. I was saying that if you go to churches, for example,
yes,
and because we say fertility, you will never see a man standing who is praying and raising and praying that no,
that is facing a problem.
That is having maybe low sperm count. You will not see that. You mostly see the women, because the general tendency is that we know that.
Or erectile dysfunction.
Exactly. That infertility is a problem of women.
Yes.
It's not true. More than 50% of couples that are trying to look for children, the cause, or one of the causes, is because the male factor. And so quick conception care is not a problem of women. It's a problem of the couple. Are we together?
Yes.
Now, you have other aspects. For example, in the past, you will hear people say that, yes, my mommy and my brother, they married, they got married, they do not have any problem. The other day we were talking about sickle cell and all the rest. And when people want to get married, preconception counseling and all the rest, they ask you to do a sickle cell test, for example. People downplay it, you see. And at the end of the day, when
they don't take it as important.
Yes. And at the end of the day, when the lady gets pregnant, for example, and they start giving birth to children that are having sickle cell, it becomes a serious concern. And so preconception care, we realize that there are some myths. We think that no, it's a woman's responsibility. We think that no, we should trivialize things and all of that, which is not true. Preconception care is equally as important as the care of the woman during pregnancy. Now, during pregnancy, what are some of the myths that you can have? What are some of the misconceptions that you can have? We have women that will tell you that we call them obrum meaning that they don't want
They don't.
and they will tell you that I don't want 5 bikini, born 4 for house, I give birth to 4 in the house. And they don't want to come for antenatal care.
Yes.
And you see a woman who has 4 children, and the 5th child, she comes and gives and dies. That's what we're talking about. You see, when a woman dies, how does it look like? It is a catastrophe, because somebody will lose a wife, somebody will lose a
mother,
somebody will lose
a sister,
another person will
the
lose
child,
grandmother, and everything, and the whole generation has been shattered like that.
Yes.
Now, what are some of the other misconceptions that you can have during pregnancy? The fact that people don't believe in antenatal care. They don't believe that quality antenatal care has an impact on the outcome of the woman's delivery or the pregnancy.
Yes.
People don't believe that they need to take the iron and folic acid every day.
Yes.
Some women will tell that doctor, when I do get for example, I will take my big roots. Enough blood. You give her the medication, she will actually gladly accept and then take it and
Keep it aside.
keep aside. Other women, for example, you tell them that you have to keep under a mosquito net. No. She will not do it.
Or they will collect the mosquito net and do something else with it.
Exactly. Those are some other misconceptions. Now, during labor and delivery, for example, that's another, you have other misconceptions. I'm sure that Mr. Wonder will have some other things to say. Now, during labor and delivery, you realize that in our context, that's why I say you should not move away from our culture. You cannot talk about maternal mortality without looking at that cultural aspect. That cultural aspect, what do we see? We see women that they've taken the hibiscus flower. You see women that have done their enema, they have done some funny things, brought some funny things in their stomach, and for some reason they have very violent contractions. At the end of the day, we are forced in some cases to break these women to move babies. At the end of the day, we have women that can uterine rupture. We have women that can what? Because when the uterus ruptures, what happens? The baby starts floating in the abdomen and you have fetal demise. And now when it happens now, we start saying that no, it is that doctor that did not want to do this, the doctor did not want to do this, and all that. At the end of the day, we lose our women, we lose our babies. And even when maybe, for example, the mothers come out alive and the baby comes out alive, there are other mobilities that come into play. Imagine that she becomes, for example, a near miss, she bleeds too much, you have to give her maybe 5 to 10 minutes of blood, for example. You see, you have to, she had that traumatic experience. You hear that maybe she has a postpartum depression and all the rest and all the rest. So at the end of the day, we have to understand that myths are there in our context. We cannot move away from those myths because some of them are imbibed in our culture. And so if you really want to fight these myths, we have to also take into consideration the cultural aspect and see how we can.
And the education of the communities too is very important. Because some of them do all those things in ignorance.
And so just to add to some of the myths, during the first 3 months of pregnancy, most women or every woman experiences what they call morning sickness, which makes them have nausea and vomit. And the community, when they sit in the community, people give their experiences. They will say when you eat dry bricks or what they call calabash chalk, it's going to take away the nausea because you don't have saliva in your mouth. And they share the experience. Yes, when you eat it, your mouth will be dry, you will not have anything that is going to irritate you. But what they fail to understand is the fact that calabash chalk contains lead, which is a toxic substance that is not supposed to be consumed. That aside, but one important thing that calabash chalk or even the dry bricks do is that they inhibit absorption of iron. So when you have a woman that are preparing to make sure that she gives birth safely, and even if she bleeds minimally, it should not affect. And then she is consuming a substance that blocks the absorption of iron uptake into the blood circulation, and that's why those women remain anemic even when they are eating what they tell you that they are eating green leafy vegetables and eating. They may even be drinking the iron that is taken from the hospital, but what they are taking, they are craving because of peer pressure, because of education in the community, is making them remain anemic. So that's a misconception that is supposed to be dispelled. People are not supposed to eat calabash chalk even when they are not pregnant because it tastes good in your mouth, but it doesn't add anything, and rather it creates you a problem. Lead is a chemical that is not supposed to be eaten. And I'm just basing on the fact that even the fact that it obstructs the uptake of iron is a reason not to even crave. We usually would teach women that they can eat biscuits, they can eat granules before they get out of bed. When they can put it by the side, they get up and eat before they step down so that it clears the gastric smell or that irritates them when they're lying down. So rather than consume things that are harmful, they should come to antenatal clinic. They will teach them what is supposed to be done to take away the vomiting in the morning hours that they have. The midwives that do that have been trained. They know exactly which thing to tell the women to eat. Of course, you may have some midwives that are not educated or who may mislead, but they are not in their numbers. If a midwife is really trained, they will know that you don't consume those things to take care of nausea and vomiting. So,
Okay. Now, I talked about this earlier and I said we were going to talk about it. I know here we have a midwife, we have a gynecologist, and I said in the cascade of healthcare delivery in maternal and child health, there are other people, both at the facility and at the community levels. Who are some of these people that we may just want to enumerate them, that at every stage they should ensure that they play their roles and take their responsibilities effectively to ensure the improvement of maternal and child health in Cameroon and beyond?
When a woman dies,
Yes.
you see, if a woman dies, for example, in this hospital, I can assure you that within 5 to 10 minutes, the whole place will recover.
Yeah.
Which means that maternal death is something that even at our local level, at the community levels, everybody is concerned. Which means that if we really want to improve or reduce maternal mortality, we need to look at it from a community or more like a global or holistic approach.
Yes.
Now, the other people, if we really want to reduce maternal mortality, like what we are saying, Mr. Mondo is saying that we have now community health workers. You see, community health workers, we have stakeholders, we have responsible people in the society. We have the churches, for example. We can go to churches, give health talks, you see. We have people that when they talk in the community, everybody listens. For example, the chief, the quarter head, you see. And so part of that health promotion that we're talking about, the ANC, is not just limited to the hospital. No. That's why in most communities, you see from periodically, you see midwives, you see community outreach, you see midwives, you see nurses. They go to the communities and try to see how they can educate the population. And one of the reasons is that when you're going to the communities, you want to see how you can also identify potential stakeholders that you can use as some assistance to see how you can maybe pass your message, for example. Imagine, for example, you have a community where, let's take, for example, maybe some of our Muslim communities where you have the imams that when they go to church, we're talking about problems of infertility being a problem of yourself, problems of men now.
Yes.
Now, in the Muslim community, for example, you have men that they go to the mosque now. Imagine a imam who is well emancipated, who is well knowledgeable enough, who can educate these men. Tell the men that your own magi for go clinic, for example. You see, because they believe in what this imam is saying, there's a general tendency that they will adhere to whatever practices that the health personnel or the midwife or the institution in that particular community, what message they are trying to pass regarding maternal health. I don't know if you understand what I'm saying.
I get you.
Yes, what I'm saying is that the community that fighting against maternal health is not a problem of just staying in the hospital. That everybody has to come and work together. We have the stakeholders. The stakeholders we have CBC, for example, is one of very potential partner to the state, for example. You see, we have the Catholic Church. We also have health facilities, for example. We have the Presbyterian Church. We also have health facilities, for example. And what again? We have we have people, for example, NGOs, for example, that are there also. For example, Mr. Monja talked about this another NGO that is trying to see how they can improve maternal at the level of the communities. So those NGOs also have a very important role to play when it comes to fighting maternal health. So you have to bring all of these people together to come out with some kind of a holistic approach that meets the needs of that particular community, because we are saying that at the end of the day, the context counts, the culture counts, if you really want to have the best results.
Thank you. We could go on and on with that because we definitely have a lot of information when it comes to maternal and child health. But then I would like us to focus a little bit now on the ALSO training that has been ongoing. I would like Madam Ba to tell us what ALSO is all about and why this training before we get to the director of ALSO.
Also, the full meaning is Advanced Life Support in Obstetrics. And the intention of also, just like we've already heard, is there to see how we can improve and standardize the care of the maternity caregivers. Also was introduced in Cameroon by Dr. Thomas Welty of blessed memory and Eddie Welty from the US in 2012. And they introduced this program where they invited people from the government, from Cameroon Baptist Convention Health Services, from the Presbyterian. Mr. Monjo sitting here was one of those that were invited during the first program, about 35 of them. And they were trained, and 7 of them made it to another round, to the next round. 7 of them were selected as instructors. And since also was introduced in Cameroon, we are not only training healthcare providers from Cameroon Baptist Convention Health Services. We also train people from the government, like doctors seated by my side here. We train people from the Catholic, the Presbyterian.
All the other denominations.
Yes, we do that. So it's not just limited to CBCHS. And since also came, I think the maternal health has really gone down within CBC.
Yeah.
Because I did an analysis taking 10 years before also came.
Yes.
From 2002 to 2012.
That is, maternal deaths have gone down.
Yes,
yes.
Maternal mortality. So I took the statistics and taking statistics from 2012 to 2022.
Yes.
10 years after. What I realized is that maternal mortality before also came was really high. But now if I had to compare it within CBC context, I realized that 10 years after also, just taking statistics from CBC, I realized that the maternal mortality has reduced to less than 150 compared to, that is 2 years ago even. So it has even gone down further compared to what doctor just reported, that is about 250 something. So if everyone can be trained in this program, they know what to do, when to do referrals, I think it's going to go a long way to reducing maternal mortality in Cameroon. Thank you.
Any other accomplishments you may want to add, Doc? Accomplishments of ALSO since inception?
Well, thank you. Just to say that Cameroon, through the CBC Health Services, is one of the 60 countries that is practicing ALSO, which is a program that is owned by the American Academy of Family Physicians since 1993. And so before 2012, maternal mortality rates in Cameroon range from 720 to 1,000 per 100,000 births. And so when Dr. Waity, Edith Waity, and the husband, they have been around before that time in Cameroon, working with the CBC Health Services as HIV, AIDS promoters and doctors. And so they experienced it. 2012 was short, just 3 years to the Millennium Development Goal, that was MR, reducing maternal mortality by 75% in all the countries. So Cameroon was still way above that target. And then that's why the Waities sought for approval or obtain a license from the American Academy of Family Physicians to carry on and implement also training in Cameroon. And when that was authorized, they brought the people Madam Ba just mentioned. There was the faculty that trained us came from Kenya, Infemet, the Department of Family Medicine in Kenya, and some from US. And of course, we had the local, one of our staff, a gynecologist that was also invited at a time to take part in the training, Dr. Tebit. And after that, they introduced, they bought the equipment that was required, and have sponsored the program, making sure that equipments are, didactic materials are replaced, and the right instruments that are needed to train staff so that they can function with confidence in delivering this care. So 720 in 2012, 2015, at the level of the country, because there was also the emergency obstetric care that the Ministry of Health was running alongside that time. The figures went down to 495 at December 2015. And it has continued to go down. And just like Madam Ba is saying, so the key achievement is that it has instilled confidence in the service providers. And if you have CBC did more than 200,000 deliveries in 10 years, and you have maternal mortality reported to less than 150,000 per 100,000, then you can understand. And where I worked in Bopi, we were doing more than 10,000 deliveries per year. I mean, we in Bopi is one of the busiest maternity next to Central Hospital in Yaoundé in Cameroon. And for the whole period, we registered 16 maternal deaths. And out of that 16, it's only 3 that came into labor that had done clinic with us. The rest were people who came in for us just to declare. Yes, they came for us just, they came in just for us to declare them dead. And yes, and so because the ministry requires that if you even identify a maternal death in your quarter, you're supposed to report. Yes, so those ones were not registered because the service providers didn't do their job well. So it shows that if everybody is trained, it is going to capacitate workers, give them self-confidence to be able to know the limit of operation and know when to move to the tertiary station hospitals on time. And that is one of the things that we emphasize. Yes, thank you.
It may interest you to know that since inception of also, the program has trained more than 1,300 providers, amongst whom are doctors, medical doctors, midwives, nurses, comcars, just to name but a few.
Yes, from what you've said, I can come to the conclusion that also is already a force to reckon with in Cameroon. I would not want us to talk a lot more on that. It's a reference already from your analysis. So before we get to the end of this program, I would like each of you to, within 30 seconds, give us your last words.
Okay, so thank you. My last words would be that every family member should take responsibility, because the care team for maternal and child health involve the family, the support system, and the pregnant woman herself, and then the healthcare team that involves the nurses, the midwives, the doctors, especially the pediatrician, gynecologists, and even laboratory technicians and ultrasonographers, because their actions have an impact on the decision that the doctors take. So we want to say that everybody should prioritize maternal and healthcare promotion, and also seek care on time. That way we will reduce maternal mortality in our country.
Yes, Madam Ba.
And I'm pleading to all pregnant women. Once you discover that you're pregnant, please go to any nearby clinic that does ANC. It's going to save you a lot. It's going to reduce work on the healthcare providers. It's going to help you a lot, help your baby a lot. And to the healthcare providers that have not been trained on also, the program is here. CBC runs the program. Please make sure you contact us so we can see how we can indulge you to making sure that you're being trained. Thank you.
Okay. Um, the ALSO faculty. What for someone like me who is from I'm not within the CDC, I would say that they should not relent their efforts. They should continue training Cameroonians. I'm here because of the partnership between the CDC and the Faculty of Health Science, University of Boya. It's through that partnership that I was privileged enough to go through the ASO provider course in 2018. That's about more than 6 years today, almost 7 years. And so when I look at the way I approached my patients when I left medical school, I mean, that experience that I had, that 4 or 5 days workshop that we had a direct impact on the quality of care that I offered to the pregnant women that came in front of me. So the ASO faculty should not give up, and that they should try as much as possible to continue training young Cameroonians, especially maybe the CTA medical students. As I'm talking now like this, I have some medical students who are I mean, they're putting me pressure. They want to attend. They want to attend. They also training, and you see, so everybody is increasing because ASO has been there, and that partnership with the Faculty of Health Sciences has stood its ground, and we have seen the results. Now, when it comes now to the pregnant woman, like what Mr. Mondra said, pregnancy is not an illness. True, we say that it's a physiological state, but the outcome of pregnancy has a direct correlation with the quality of antenatal care that she will receive.
Yes.
And so when she gets pregnant, she should seek quality care. Now, how do we offer quality care to our patients? The ALSO faculty is coming what we call evidence-based medicine. What has worked elsewhere, and so far we are seeing that it has worked in our context. And so for a health personnel who has never attended the ALSO training, I will encourage that person to see how they could look for some liaison to see how they will get access to the ALSO faculty so that they can also train their own personnel, and on a global scale or at the national level, we see how we can actually continue to really fight this maternal mortality that is really, really a problem in our context.
Today in our program, we had Mr. Munjo Anthony. Mr. Munjo Anthony is a hospital administrator and he is the director of the ALSO program for the Cameroon Baptist Convention CBC Health Services. We also had Mrs. Mba Rihel. Madam Mba is also an administrator and a specialist in maternal and child health, as well as a researcher in this area. And we had Dr. Milton, who is a gynecologist. We want to appreciate all of you today for the information, very valuable information you have shared with the audience. And for presentation, my name is Clementina Njang Yong for the program Health and Beyond, a production of the communication unit of the Cameroon Baptist Convention CBC Health Services. It's been the program Health and Beyond, where we have up-close interviews with professionals in the health sector to enlighten communities on health-related issues, as well as other topical issues beyond health. The program comes face-to-face with people who have valuable information for public consumption. Thank you for being with us.